Hi, my name is Dr. Michael Chiorean, and on behalf of my co-investigators, I'm pleased to present the abstract titled Disease Burden and Treatment Patterns Among Patients with Ulcerative Colitis with Isolated Proctitis in the U.S., a real-world study. Approximately 30% of ulcerative colitis patients present with isolated proctitis. These patients have been typically excluded from most clinical studies of advanced therapies, and therefore information on disease impact and treatment evolution is scant. This retrospective observational study aims to describe the disease burden and treatment patterns among patients in the U.S. with isolated proctitis. Patients with ulcerative colitis were identified from a large administrative database with an index date between 2016 and 2020. They were subdivided into patients with only isolated proctitis, which we labeled IP only, and patients with more extensive UC, which we labeled UC. IP patients were further stratified in patients who required only rectal therapy at baseline, labeled RTO-IP, and patients who required other therapies beyond topicals, labeled BRTO-IP, based on ICD-9 and 10 coding. Rectal therapy only included patients with no ulcerative colitis treatment or rectal treatment only, such as mesalamine or corticosteroids, and beyond rectal therapy patients included those treated beyond rectal only therapy, such as corticosteroids, oral, rectal, or IV, mesalamine, oral, thiopurine, immunomodulators, biologics, and small molecules. A group of matched controls without IBD was also assembled from the same database as a reference, and we labeled those non-IBD. Overall, both the IP and the ulcerative colitis populations had higher rates of clinical and mental health burden, exemplified by anxiety, depression, abdominal pain, and fatigue, compared to the non-IBD population. When assessing medication use from index to 24 months of follow-up, rectal therapy-only isolated proctitis patients had increased rates of conventional therapy, including corticosteroids and thiopurines, as well as advanced therapies, while the BRT-IP patients saw an increased use of thiopurines, biologics, and small molecules. Treatment intensification during this time was more common in the BRT-IP cohort. Evaluating healthcare resource utilization over 24 months, the beyond rectal therapy isolated proctitis cohort had higher mean rates of ulcerative colitis-related outpatient visits, treatment, and pharmacy costs compared to the rectal therapy proctitis and the ulcerative colitis cohorts, with beyond rectal therapy and ulcerative colitis cohorts having higher total costs when compared to the rectal therapy only. All three cohorts had higher medical and pharmacy costs compared to the non-IBD group. Limitations of the study include potential miscoding, missing comorbidity confounders, compliance data, and lack of disease severity data. These findings may not be generalizable outside of the US or the insured population. So, in conclusion, overall patients with ulcerative colitis, including those with only isolated proctitis, had a higher somatic and mental health burden compared to non-IBD controls. Corticosteroids use was high across all proctitis cohorts. In addition, about half of the patients with isolated proctitis required treatment intensification over the 24 months follow-up, and the beyond rectal therapy proctitis cohort had healthcare resource utilization and costs of care that are similar with patients with more extensive ulcerative colitis. Further studies aiming at the identification of risk factors and treatment optimization in this relatively underserved subgroup of patients with proctitis are warranted. Thank you very much for your attention.